Hi, this is Colleen Parsons with your Heart and Neck Vessels lecture, part 1. This corresponds with your cardiac skills assessment. We're going to review this in class, but there's a lot to the cardiac skills assessment, including we need to know all 4 major valves of the heart: aortic, pulmonic, tricuspid, and mitral valve. Where they are, you need to be able to palpate them. You need to be able to listen for the extra heart sounds as well, and murmurs, as well as their primary sounds. And you listen to the primary sounds with the diaphragm of your stethoscope and the extra sounds with your bell. We're also going to inspect the jugular venous pressure, hepatojugular reflex, all of your peripheral pulses, carotids. Carotids you will do singly, everything else you will do symmetrically, and you will learn advanced assessment. And it's very important to do your advanced assessment for your DVTs, and you'll be learning something cool called the Allen test. Make sure you take advantage of the online information that's available to you from your textbook. You paid a lot of money for that textbook, so I'd make it worth it if I were you. They have great videos. All right, so I'm going to skip through a lot of the anatomy, anticipating that you have already had this, and then you just need a quick review. The one thing I do want to remind you is that the base of the heart is really at the top of the heart, what we consider the top of the heart. So here is the base of the heart over here, and the apex of the heart is down here. Okay? The pericardium is this whole area here. Again, base of the heart, the apex of the heart. Your cardiac cycle, remember what that is and why that's important. We're always talking about diastolic and systolic blood pressures, having an understanding of what that means so that you can intelligently talk with physicians and the rest of your team, as well as being able to interpret what they're saying for your patients. Understand how the right side of the heart and the left side of the heart are different and why. You're going to need to know this, especially next term or med-surg. So the first heart sound that you hear is S1, and you will be listening for S1 every time you listen to a heart. And the second sound you hear will be S2. There are other sounds that you'll hear. Those are the 2 sounds that you want to pay attention to, especially at your level of understanding. And know how respiration, now you can begin to see again how everything is woven together. Our whole bodies are woven together. So the effect of respiration has on the heart is very important, obviously. So your extra heart sounds are S3 and S4. Murmurs are particularly concerning. Some murmurs don't cause much of a concern for physicians with the patients, and children born with murmurs often outgrow them. And what that means is, as the heart matures, the valves do grow into themselves and are able to close. But other murmurs can cause life-altering problems for a patient, and they can be very significant. So hearing them, picking them up, and seeing what you can do about them early on. The earlier the better for the outcome for the patient, as in almost all things with regard to healthcare. When we are listening to heart sounds, we're listening to the frequency or pitch, as well as the intensity or loudness. Are they loud or soft? The duration. Is it very short? Are they long? Are there silent periods? And the timing. What part of the cardiac cycle is that occurring in, that sound occurring in? There are many problems with the electrical systems of our hearts, and we're learning more and more about that as we go. When you are taking an ECG or EKG, there are waves that are labeled PQRST. Now it gets kind of confusing because this is also this is how we remember how to evaluate pain. So sometimes we're talking about an ECG, other times we're talking about pain, and how you store that in your brain so that you can recall it later is going to be important for you. I'm not going to go into any more of this except to increase your awareness here. You'll get this all when you take critical care. The neck vessels are particularly interesting from an assessment perspective because they will change. We can pick up a lot of what's going on with the heart by assessing the neck vessels. So both the carotid arteries and the jugular venous pulses and pressures. It will be important for you to review the how infants and children's hearts grow. The fetal heart begins at about 3 weeks of gestation, and it continues to grow. If women, especially in the olden days before easy over-the-counter pregnancy tests, didn't even know they were pregnant most of the time by the time they were 3 weeks. They never went to the doctors until they were 6 weeks pregnant. So this is very soon. This is only 1 week after a missed menstrual cycle, and that's a pretty early heartbeat there. So we are beginning to look at how to take care of a fetus before the woman is even pregnant. And then pregnancy has a lot of complications when it comes to cardiac involvement. And the aging person, depending on what their lifestyle has been, smoking, diet, exercise, they will all have an influence on the cardiovascular system. The veins and arteries become stiff as we get old, just like everything else becomes stiff and a little bit weaker, allowing the aging process to allowing ourselves as nurses to better understand the aging process and how that affects our patients is incredibly important for proactively helping them maintain as healthy a lifestyle as possible. There are hemodynamic changes, arrhythmias. Most of you have heard of AFib because it's popular on television right now. I have many friends with AFib, atrial fibrillation. Culture and genetics also influence the cardiac system, and more than 1 in 3 have some forms of cardiac disease in our country. That's been the leading cause of death for men and women in the past many years. And one of the interesting things is women do not have as many cardiac issues going on for them until after they've reached menopause. And then once that occurs, they kind of catch up with men. So you can stop these and catch all of the, or go to the lectures and look at the slides yourself. I'm sure all of this data is in your book as well. Smoking has significantly declined, but there are quite a number of people who smoke. So people who smoke have a tendency, not always, but have a tendency to be in the lower socioeconomic area culturally, and that is pretty systemic. Patients with significant chronic mental health issues also have a tendency to be smokers, and there are some reasons for that, but that smoking impacts many things for them, especially if they have pre-existing conditions. And one of the things smoking does is, so patients are admitted to the hospital, they are smokers, we put them on smoke cessation medication, nicotine patches or whatever. They stop smoking while they're in the hospital. I'm going to talk specifically about mental health patients. We get their medications all adjusted, but this is true of many medications. We get their medications all adjusted. Then we let them go. We discharge them from the hospital or from a well-organized healthcare situation, and they start smoking again. The actual smoking inhibits the absorption of their medication. Their medication isn't absorbed as readily. So then they start to have symptoms again, and they become hospitalized again, and we're on this whole vicious cycle. So smoking isn't good for many reasons, and that's one of them. Obesity obviously is also a problem for cardiac issues, as is diabetes. So we continue to have these comorbidities that influence every aspect of our health care. And there's the end of part 1.